We're going to return to Hebrew. If you need any interpreting for English, please use your earphones now. So the second session will address health inequality, the intersection of geography, poverty, education, ethnicity, and gender. The chairman is Dr. Sagit Arbel-Alon. She is the chief physician and director of the health services system in the Ministry of Welfare and Social Affairs. She is the initiator of the welfare medicine. She's a gynecologist. She she occupied many important roles in the Ministry of Health, and she's also a colleague, a dear colleague, and she's also a poet, for those who don't know. And she will also present the other speakers, Sigal Regev, the CEO of the Meuhedet HMO, Professor Sarab Rabia-Queder, Vice President for Diversity and Inclusion at the Ben-Gurion University of the Negev, Idan Greenbaum, Head of the Emek HaYarden Regional Council, and Yael Sherer, Founder and Director of Survivors of Sexual Violence Advocacy Group, Israel's Lobby Against Sexual Violence. Thank you, Nir. Welcome to all the participants of the panel. I shall present you one by one. So Nir said that I'm a poet. I will start with a poem, not a poem of my own. It was written by Orit Klopstock, who is a social worker, and she writes the following. I addressed the project for reducing poverty, and I asked for false teeth for nechama, which is a very important weapon in fighting ugliness. It was approved. Nechama came back with a smile. Poverty looked out of her eyes. So please thank me for not giving you any more. Those who participated in the poetry evening, which I organized, will remember it. Anyway, inequality in health, of course, harms not only health and well-being or welfare, or as we like to call it, the wholeness of the individual, but every particle, every detail in our life. The main perception that the health system set to itself in the last decade and has been operating in that view is to set the individual at the center, which is a perception that was designed to render the reduction of gaps and inequalities easier. And it has to do on the core issues of the Ministry of Health. And we also heard in the last lecture, but all along this day, this fact did not change the map considerably or significantly, and neither did the perception of the Ministry of Health as to how far its responsibility lies, also in education, also in welfare. Where does the health system terminate? So these are two main perceptions, many programs supporting them, and these circles of equality, the mills of electricity are milling very slowly, too slowly in my view, and I will take the liberty of saying that we are lacking many stakeholders in this room, such as the industry, business people who should be an integral part of the stakeholders in this issue in order to ensure change. This habit of speaking about these differences from the point of view of poverty, gender, etc., education, geography, etc., does not really conquer the inequality, does not abolish the inequality and the discriminating policies, the social agreements which do not tally with what is considered as fairness in society. In this panel, we'll try to expand our view concerning education, groups of handicapped people, victims of sexual abuse, etc., And we will try to really, in all humility, try to shed a little bit more light on this and to propose to policymakers more ways of pursuing this very important track of reducing gaps. And the question that we will ask loud and clear, is how do we join hands? The first one will be Mrs. Sigal Regev, who's the CEO of the Meuhedet HMO, the first woman elected to head an HMO in Israel. Sigal really broke the glass ceiling and changed the rules of the game. And now, in what was considered until then distinctly male territory, as a CEO of the Meuhedet HMO, she led many reforms, the digitization of the medical services. If you are familiar with Sigal, you know that her motto is that nothing is impossible. I can do everything and anything, and I can enjoy the process, not only the outcome. This applies, Sigal, also to reducing gaps and inequalities in health. So, Sigal, the floor is yours. After such an introduction, all I can do is just ruin it. Hello, everybody. I'm very happy to be here today, and I am thankful to you for having invited me here. I was allocated a few minutes, and I'd be happy to share with you my insights. And my insights stem from two HMOs, the Meuhedet, in which I've been serving for 9 years, and another one, a small one, Klalit, that's the largest in Israel, where I was serving for some 30 years. So from those two HMOs that address this issue of reducing gaps and inequalities, and I would say also that the Ministry of Health has placed this program, remind me, I believe it was 2007 or 2010, really on our agenda as one of the issues that our system should address. But those who are in the HMOs had to face that all the time because it's an integral part of our responsibility. Let me share with you some insights. When we started to address the issue of inequalities and gaps, everybody said geographical periphery. And we started looking at the data and we said, what does that have to do with geographic periphery? No, it has, we looked at the periphery, wonderful outcomes, very good life expectancy, very low babies, mortality, etc. And we started to check, and we saw that had nothing to do with periphery, but rather to poverty, to SES, to education. And all these have an impact on the capability to better understand and to hold and to master and to consume medical services and healthcare, which is equal, which is provided everywhere in the same manner. So why does it succeed in one place and does not succeed in another place? So we looked at the data, and it told us a different story than geographical periphery. We could see that in the east of Rishon and in Ramle and in Jaffa, and in the older, poorer areas of Ramat Gan and Tel Aviv and Givatayim, we have the same outcomes as in Yerucham, Dimona, and even in Dimona, not every clinic had the same result. So we came to the concept of the backyard clinics, which are to be found throughout the country, but this issue of the low SES and poverty, how to be your own advocate, and manage your affairs in a better way. That was our first insight. And the second one was, I said, okay, let's have improvement teams in every clinic. We have the National Institute. We have 64 indices that we had years ago. Let's say we'll score everyone. We'll take those national scores and we'll compare. And we saw that there was quite a lot of gaps between these, and we decided to have improvement teams. Okay, so we appointed improvement teams. What happens? Okay, you can see improvement, you know. An improvement team brings an improvement, so we were happy. We danced around our desks, and then we said, let's stop the improvement teams. Okay, they've done their job. Now everybody understand? Let's stop them. And the result was nil. And then we had a very important insight that when you stop, it goes backwards. It takes a little time, but it goes backwards. In other words, if you do not invest the same energy in continuance, it goes backwards. And then we understood one more thing, that the time of the treating staff, physicians, nurses, etc., that the time that they need to invest in that population where there are gaps is much, much bigger, longer.
one size fits all.
So we usually tend to work in a system of one size fits all. And we adapt the quantities according to capita, according to age. And we did not do this by the time of understanding how much time should be devoted. But we understood that if we continue to work like this, we won't get anywhere. And what we need to do is to really build a completely different treatment environment in the clinics, which of course requires to do all kinds of clinics, not necessarily a clinic where people need only a doctor or a doctor and a nurse. And we see that if we have a multidisciplinary team, it's very helpful. Turns out to be very helpful. We did it in several clinics. It's not simple, of course. And of course, it is manpower intensive. And we have to start moving people from one clinic to another. You know, the positions, number of positions, it's quite problematic, but this is one of the most significant insights that we have. So because we had thought first, you know, just an improvement team and that's it, but once they leave, we go very quickly backwards, back to square one. So this was an added insight. Another thing we understood is that there are things that it's very easy to just do a V on, you know, done, to check it. Accessibility, for instance. Okay, it's difficult to get from Dimona, Yerucham, or from Kiryat Shmona to a place where one can have a mammography. Okay, so we have the mobile mammographies, or we have those mobile units for prevention. We can bring them, and then, okay, another V, another check, 70% of people did a mammography. Nice, but that's not our health. We understood that primary healthcare is the one that really modifies things, that has a tremendous impact on the life of our patient, so that he or she can reach older age after good maintenance. So it's nice to bring mobile mammography or to bring mobile units to the Bedouins, for instance, that bring all kinds of equipment for doing examinations, but that's not medicine. The primary clinic that should provide the core treatment, and that's where we should concentrate. One more thing that we learned, that when we checked the backyard clinics against the rich areas clinics, we had a gap. And we could see that this gap is maintained. Everyone improves, you know, the backyard clinics improve, but also the richer areas clinics improve. So the gap is maintained. Another thing we could see, and that's, by the way, mind the gap, you know, the gap is maintained because everyone improves, which is important, but the gap is still maintained. And that is very important for those people who engage in research. Even when it succeeds, the gap remains, there's something that has to be addressed here in the longer run. And you have to evaluate this with the correct indices and measuring in tools. One more thing that we learned is that when you build a team around the patient, it also needs to learn how to consume it. Okay, you have a social worker, you have a case manager, etc. But they have to learn, they have to exercise how to work with such a team, because you can place a team and nothing would happen. So there is a question of training the population to consume these healthcare services in the proper manner. So you have to segmentalize the population, see who needs mostly a doctor, who needs a doctor and a nurse, who needs a doctor, a nurse, and a social worker, who needs a doctor, nurse, social worker, and a psychologist to get a better outcome. It's very difficult to do. It's rather tailor-made. You can do it also in various clinics. Well, I was told time out, so I have more insights, but these are, let's say, our main insights from over a decade that we have engaged in this area of inequality, of trying to reduce inequality. I believe geography is of lesser importance, and primary healthcare, appropriate primary healthcare, can definitely bring about a change in this field. With the addition of the mobile units, the digital, etc., many things can be done from afar, but an investment in primary care is definitely a major factor. Thank you to all of you.
תודה רבה.
Thank you. The next speaker would be Mrs. Yael Sherer, the founder and director of the Lobby Against Sexual Violence. She is a writer and director of documentary films, and I can tell you that for many years she's been pushing us behind the scenes, in front of the scenes, to be better. She was awarded the prize of Women Who Changed the World from the Knesset, and also in the Miss Fix the Universe of the Women's Lobby in Israel. And on the 74th birthday of the State of Israel, of the independence of the State of Israel, she lit a torch in honor of these organizations. In a criminal procedure against her father, she petitioned against the state to have an open court case and to testify open-faced without being masked. She, in 2019, she set up this lobby, a civil organization that engages in promoting legislation which has had a lot of success. Yael, the floor is yours. With your permission, I will not speak from the podium. Yes, are you sure?
אני לא כל כך אוהבת פודיומים. סליחה, עמכם הסליחה.
I'm sorry, but I don't like podiums. Hello, I'm Yael Sherer. Like Sagit said, I manage the lobby against sexual abuse. I was abused by my father, sexually abused by my father, and I am at the head of an organization that addresses legislation and policy making. But some 10 years ago, I sat with victims in a room of social abuse, and we started talking about all kinds of health issues that we suffer from. Everybody seemed to suffer from the same issues. We had a checklist of health problems, and I started thinking that there is perhaps a common denominator or a link between those things, because it didn't seem to be a representative sample, but if we all suffer from the same things and we are all in the same room, it seemed a bit strange that these things would be not connected. So I started talking about it, and I was told that these things are not connected. I'm quite sure that when people who sit here in this audience, it seems to them that it is perhaps not entirely connected. And why did they bring someone who addresses sexual abuse to a panel that addresses health issues? Well, the truth, if the truth be told, is that for some years I was myself challenged by this, and I didn't understand why I'm so captured by this issue. When I started working with the Ministry of Health, everybody explained to me that all this issue of sexual abuse is not an issue of health, it is an issue of social work, of welfare. And until recently, everything that had to do with the health of victims of sexual abuse in the Ministry of Health were under social workers. But I started getting interested in this and to read about it because I could not believe that I was imagining this connection. And I came to documents of the WHO, and what do they say about victims of violence and sexual abuse? What do they say? They say that it is a disease. They say that in fact, that what they imply is that I was not the only one to see the connection. And when I started reading about this issue of victims of violence and sexual abuse as a disease, it has a lot of repercussions. So after they told me that it's not connected, I started finding research which established a direct link between sexual abuse, especially in childhood, and heart problems. Now, what kills most people in Israel? Heart conditions. Now, why is there a connection between a sexual abuse and a cardiac, and a morbidity of the mouth and teeth for instance. Why is that connected? Why is it connected to skin problems? And research that was published in the United States by insurance companies. Insurance companies wanted to know how long they will have to insure such a patient and how long will it cost them. How much will it cost them? And they found that people who had traumatic events in their childhood, including and specifically sexual abuse in childhood, if it went beyond a certain number of times, beyond 6, and believe me, I was attacked more than 6 times, the life expectancy of these people will be shortened by 10 to 20 years. This is not marginal. I celebrated my 40th anniversary a month ago, and if the life expectancy of a woman in Kfar Saba, say in Israel, is 80, that means to say that I, a young woman, relatively young woman, if that those averages are correct, I may live 20 years less. That is until the age of 60, and that disturbs me. But am I the only one in the world who was sexually abused? Definitely not. Israel resembles the OECD average, the European average. So 1 out of 5 women in Israel would be raped during her lifetime. 1 out of 36 men. 1 out of 5 children would be sexually abused, both boys and girls, until the age of 12. So if I throw a figure and I would say that 1 million people were harmed sexually, I would still be conservative in my evaluations. The OECD values that at a higher figure. And still our health system does not speak about it, does not treat it. Even though these women, we will live much less a longer life. There will be a higher morbidity rate and also probably morbidity rate. These people will either abuse the health systems or will not do anything. They will not do a mammography or a PAC. They will die much more of cancer. And the health system speaks about gaps and inequalities. You all heard today. How do we do health for the Haredi, the ultra-Orthodox population? How would we do that for the Arab minority? These populations are not transparent because everybody speaks about them. But this particular segment that I'm speaking about is transparent. Nobody speaks about them. Nobody wanted to hear about it because sexual abuse, so-called, does not belong to health. It belongs to social welfare. After Freud, they agreed finally that it has to do with psychiatry. But what I'm telling you is that the most transparent population is the one that is not talked about. No programs, long terms, not a decade program is made for it. It's not included in anything. They did not talk to you about it. And none of the reports that you will read, even though this sector is definitely distinct, definitely diagnosed, and we need a lot of specifically adapted medicine. But we are at the very outset of this. I'm very happy that Sigal is here because the HMO that she heads is the first one that launched a program especially tailored for sexually abused people. The other HMOs are beginning to close the gap, but they are only at the outset. And we're going to start with hospitals. And I have to tell you that this is still in its very first stage, but in the world as well, they're starting to speak about it, and interest is increasing. And I was invited to the UN to speak about these models of the Meuhedet HMO and of others to address victims of sexual abuse. And from these 2 days of invitation to the UN, with a huge quantity of people who heard me and wanted me to talk, this has turned a tour of a whole week, and thank God it's not at my expense. Thank you very, very much. Thank you, Yael. When I read the CV of Professor Sarab Rabia-Queder, I said to myself, I wish she would agree one day to be my friend. Professor Abu Rabia is the Vice President for Diversity and Inclusion at the Ben-Gurion University of the Negev and an Associate Professor in the Education Department. Her research addresses marginalization among the minority members, women members. She is a leading researcher in gender studies in the Bedouin society, and she's also a feminist activist and is a member of different academic and other boards. She acts in favor of Arab women, Bedouin women, fighting polygamy and improving employment opportunities. She was awarded many citations and prizes, and she was elected as Woman of the Month by Current Sociology. So, Professor, the floor is yours.
I would be your friend gladly from this day. Would be my honor to be your friend. I hope again I'll be a part of the schedule, if not affirmative actor for minority groups, right? So thank you to Professor Nadav Davidovich, who insisted on inviting me to again on a conference on inequality in health services. Although I come from the higher education, sociology of higher education, I would like to share with you my recent study, who dealt again with racial discrimination against women, Bedouin women in the workforce in the Negev. And we also have professionals from the health services who work in our sector. And the book was called Status Identity in its formation. I'm actually showing a multidimensional approach to racialization, or processes of racialization. I like the approach. It's a macro approach that deals with structure, policy. Then there is a meso level, which relates to the environmental context, syllabus, socioeconomic status, etc., especially, branding, labeling, and then the micro level that relates to the interactions and behaviors on a daily basis between people. This approach is very important as far as I'm concerned, because it enables us to expose the discrepancy between the policies and the practices on the different levels in every area, by the way, not only in the area of education. My research population included 50 women. This is a qualitative study which was based on narrative interviews, in personal interviews in their professions. There were nurses and educators, social work, scientists, physicians, school principals, some of them were even pharmacists. Let me just skip quickly between the slides to show you everything. The main hypothesis in the research was to examine the mechanisms that create those multidimensional racism among professional women in that middle class sector, among the Bedouin community in the Negev. Although, again, those women have higher educational capital, so to speak, in their own society, they were still subject to multidimensional racism. And the main hypothesis is that when their professional status comes across or has to cope with attitudes around them, what is called intersectionality from the hegemony or that patriarchal approach, because of ethno-social labels, that creates the inequality. First of all, I use the intracategorical analysis or intersectionality, which is also, again, the subcategory is intracategorical analysis, which focuses on one particular social group with the aim of exposing differences inside the group, and enables us to identify invisible groups, and also exposing different layers of repression. And that is why the qualitative or narrative approach is what is best here. I'm talking about representational intersectionality, which is basically cultural construction of, again, racial mechanism that stem from colonialism and other such hierarchies. Let's go to the statistics and to the findings. We are talking about four main indicators indicating racialization on different levels that I built for you. Let's begin with little taste of each indicator, and I hope I'm able to go over all of these. The first racial indicator, which is basically discrimination on basis of ethnicity, is based on some sort of differentiation between us and them. they create exclusion, boundaries, and also limitations of exclusion and inclusion of the, for example, the Bedouin working woman in Israeli society. So you can basically sort of sum it up in a nutshell and say, to prove that you are professional, you have to prove you're professional despite the fact that you're an Arab. And then we have discrimination on the part of the employer and on the part of the patient or the client, especially in the health services and within treatment frameworks. For example, differences in culture, using cultural discrepancies in order not to promote women, or not promoting women as a result of them being labeled as traditional birthing women, exploiting again their dependence on their employer, and some sort of a patriarchal attitude, meaning nurses that come from unrecognized unofficial villages and can't really join a couple because they don't enter those villages. And there's also discrimination on the part of the employer or even the client. There are a few discriminations here. I'll relate to a few of these. And there is that silence discrimination, and of course that fear of speaking in the Arab language. We have that unspoken racism. You can see the testimony of a woman. I always felt that I'm different. I felt that my employers don't believe in me, although I was always excelled in everything I did. I always felt that I'm worth less. Sorry for running. As to those traditional roles, it's basically an attempt to try and stop. Sorry, this is invisible racism. You can't really prove them with any figures, but there is a phenomena that is manifest. One of the nurses that wanted to be promoted and take on a more senior job, she had to take courses to complete her academic degree in nursing. She said that people started laughing at her, that she has many children, that she can't leave her kids. Meaning there's a continuation again of follow-up of using those traditional labels of gender labeling in order to stop her promotion and not enable her to move forward. Again, this very hostile sort of otherness and being wary of using the Arab language in the environment, being very scared of reactions by clients. Also in times of war down south, there is always a tension in expressing your opinion or speaking about your identity, which creates this feeling of not belonging. Some of the interviews said that this is more intensified when the employer asks them to speak with the clients, the patients, only in only in Hebrew. There's a number of reactions here, you can see, but I'm going to move forward. Okay, the second sort of find is the politics of fear, which is discrimination because of external attire, covering your head or whatever it may be. There is Islamophobia, the fear of the Muslim religion or whatever represents the Islam. And in the book, I've given many examples of such cases where, again, people are not willing to accept women who cover their heads because of that head covering or having some sort of representation of their religion. Before you signal that I have 1 minute left, let me just talk about that sort of institutional contract or tribal contract. There's some sort of a covenant between that patriarchal tribal institution and the hegemonious institution when we're talking mainly of employees that work in the therapy, social work, even lawyers who work with, again, women in distress and children, psychologists who try, and even counselors and educational psychologists within the school, which is part of the system, that come across that tribal code and the professional code. Let me give you an example. The social worker, wants to go on a home visit and try to intervene in the family circles. It's called intervention, right? It's professional intervention. That professional intervention is translated or is, again, perceived by the tribe to which which the family belongs, where the intervention takes place, as an intervention that is prohibited or forbidden or something that cannot be done because she crosses those tribal borders. And that intervention, again, comes at a price in her family, the professional. I mean, sometimes they can even sue her or even her father. The tribe may sue her for intervening with other families. and that neutralizes her. What is even more dangerous is when those workers, whether it's consultants, psychologists, social workers, when they try to turn to again, that one institution, the employer, he usually cooperates with the tribal codes in most cases, and that is how treatment is prevented. Proper treatment does not take place. And again, when an Arab employee cannot use Arabic, she cannot give treatment because she doesn't have support, not from the tribe nor from the institution. Many Arab women say that they have left the place of work or have left the sector. Instead of working in the Arab sector, they go and work in the Jewish sector instead. Now, these sort of tribal institutional contracts is what Crenshaw calls that intersectionality. That means that one chain of power comes across or intersects with another force of power, and I think this has come up in different presentations. It creates some sort of homogeneity. There is a very sophisticated, invisible discrimination as people are promoted, meaning the more professional you become, as you are promoted professionally, the discrimination becomes sort of more implicit. Laula explains that inequality is not only measured in the economic terms of the labor force, but also through symbolic and cultural representation and recognition. So again, the fact, does this go about? Not recognizing those professional women who bring, again, to the different arenas, and it is manifest in those recurring attempts to try and police those women and placing them into molds and leaving them fixed and stagnant. And in this sense, it's done by replacing that identity with a cultural one. Thank you so much.
תודה רבה רבה.
Thank you so much. If you asked, about, what's the connection between education and this session, I think you explained it very clearly and easily. Now, in order to transition to the next speaker, I would like to read another poem by Rick Klapsop. It is called Aid, or Ezer, who threw the sandbox and he hit the grape juice of Kiddush. It was thrown on the walls, signs, blood signs on the welfare walls. But then he looked at me. I was like Rachav the whore. I buckle under the poverty line. I see his underwear, a sick woman, hungry children. Holidays are a scary word. Our next speaker is Mr. Idan Greenbaum, who is the head of the Regional Council Emek HaYarden since 2016. And from 2018, he's the chair of the Kinneret of the cities, which basically regulates tourism in the area. Anna Lerner, who was the head of the policy planning, and she actually would tell us that for years we have been dreaming for there to be some sort of health agent in every regional council. I wonder what you think about it. Before taking up this position, he works in the military. He has an MA in political science. He is married. He has 4 children. And he lives in Ashdod Yaakov Ichur, which is a kibbutz. He was responsible for missing in action persons in the military, just to mention that. So I have somebody, again, an official that's responsible for me. She started off with a 3rd-time position during COVID, and COVID again promoted her. She's now full position plus some. Thank you so much for inviting me. I'm so happy to be here. And finally, there's a panel in the state of Israel where there is 1 man and 4 women. So chapeau to all the organizers for that as well. just to follow up what the previous presentation said, I heard about that local level by the English-speaking keynote lecture. And it's, of course, the local level is very important, but if the national sort of level creates some sort of a policy or imposes tax on sweetened beverages and such, then what can the local level do? I mean, our power is limited. So let me just take the few moments that I have in order to share a number of points with you. Again, from the depth of my heart, from the blood of my heart. The only reason that I'm standing here today and talking to you is in merit of the health. It's because of health. Because if I had not come across those health discriminations personally, I guess I would not have run for head of regional council. Let me tell you the story in a nutshell. For more than 20 years, I lived in Tel Aviv. Not in Tel Aviv, in Ramat Aviv. That is where my kids were born. And at some point in time, we decided to try relocate and go back to the place where I was born. And you know, when you go visit your parents, you don't see reality as it is. You know, it's a sort of external perspective. And when I lived in Ramat Aviv, I would leave my house, and around me, I would have all these HMOs, you know, I could go with my kids to the Klalit HMO next to the mall, and they would welcome me, and then I would suddenly I would right away go to the pharmacy that was close by, and then we moved to the Jordan Valley, to the kibbutz. And in the Jordan Valley, there's a regional clinic. This was 10 years ago, and I was shocked. You know, even the most basic need, you know, it might seem very pretty trivial to you. When you leave your physician and you get a prescription, right, you want to go to the pharmacy and get your drugs. We didn't have that because the pharmacy was opening hours didn't overlap the clinic hours, and the nearest pharmacy is in Tiberias. So if somebody sitting here might say to you that the geographical periphery is not that significant, oh boy, is it significant? Not only because of health reasons. My mom, who's 89 years old, had to go to a pharmacy in Tiberias taking 2 buses. She's not going to do it. You know, at least she has a family who would take her there. But if somebody else has to go to, you know, to see a specialist and taking 2 or 3 buses to see one, he's not going to go. Even if he'd have the best specialist in the neighboring city, he's not going to go, because it's not only about medicine, it's about transportation, about many other things as well. And unfortunately, when I went back to the Jordan Valley, I decided I would take this issue upon myself, the health issue. And I actually established this whole clinic for the Jordan Valley. I have a Facebook back. This was completely voluntary. It was private. And I started really bugging the Klalit HMO. I wouldn't let them go. Back then, the Klalit, you know, HMO said, wow, we have internet in our clinics. It wasn't even that common back then. And we have internet in our clinics, but not in the Jordan Valley clinic, because the natives in the periphery, they don't need internet. So yes, I waged war even for this little trifle. And no less important than this, I started organizing the community, started recruiting the community. As was said, the community is significant. And back then, we brought, again, the director of that district, the Klalit director. For the first time, he met his clients in the Jordan Valley, and he heard from them directly what it means not to have accessibility to health services. And you are familiar with the statistics and figures and how many beds there are and the mortality rate. You know that. And I think everybody knows how to spit these figures out. But in real life, this situation is far more complex, because at the end of the day, in our area, and it's not with our low socioeconomic status. We live in the kibbutzim. We're okay, despite all the crises. But at the end of the day, The fact that we don't have accessibility, people just give up on healthcare because they don't want to put somebody out of their way to take them. You know, we have a skin cancer from way back when people used to take their sun bath every day. But we don't have a dermatologist in the area. And then there are new inventions, lovely new inventions. Hybrid medicine, right? You know, hybrid medicine, it's wonderful. It's advanced. Now go explain to somebody who's 70 or 80 years old, a kibbutznik his entire lifetime, that there is hybrid medicine. And now all he has to do is to connect, take a picture, send it to the doctor. The doctor will give him, will help him. It just doesn't work. And usually they carry out these experiments in our area, that hybrid medicine, and they don't do it because of, in the name of sophistication and progress. They do it because of distress, because they can't bring physicians to that area, because the regional head of council, at least me on a personal level, when the Klalit HMO says, oh, we found a great GP, by the way, for you, why don't you help us bring him over to your area? I try meet this physician or with a spouse, depends if it's a husband or, again, a male or female. I try to find him a place of residence, accommodation, transportation. I know that if the spouse doesn't have a job in the area, they're not going to come, and a place for the kids. We really take on this mission, and we do it willingly for the with the purpose of improving our reality, the reality that we have to cope with on a daily basis. Let me just sum up this part of my talk. The geographical periphery in the state of Israel. You know, this discussion, this debate about gaps, it's a daily reality for us. The fact that there is no competition. I don't have competition in my area. You know, Sigal will be angry. I just have the Klalit HMO, just with the cellular phones, that nobody should tell you these stories. The minute there'll be another HMO in our area, and I've been trying to bring another HMO to our area, maybe something will change. Only then. And I'm not successful. Why? It's not worth their while. And despite that formulation that we call capitization, and the HMOs get more per capita in the periphery, I'm not able to bring any HMO to our area. And I'm left with Klalit, the same Klalit HMO, although I've spoken with the director of the district and all the debates. Klalit knows at the end of the day that even if the service is not that great, who else will I go? Where else will I go? So Beit She'an has a Maccabi HMO. Okay, great. That really, you know, gives me a, solution to my problems. But maybe I will talk on later during Q&A time of what happens when you create a rehabilitation center for the northern periphery and other challenges that we are coping with in terms of health. So this was a little taste, just in a nutshell, and please just remember that we are not talking about the health system only. If we don't start relating to this reality, again, in a holistic fashion, of integration of transportation, health, and many other areas, we will continue standing here screaming out and pointing out what great discrepancies there are between the center and the periphery.
טוב.
Okay, so the next moments, do we have that PowerPoint? So let's devote the next couple of minutes to the issue of inaccessibility to people with disabilities. Again, as the head physician of welfare, I have a lot of examples about inaccessibility. Today I chose the people with special needs or disabilities. It's amazing that there are, again, health services in welfare because we're responsible for welfare. But not only, we're also responsible. Of course, the Ministry of Health is responsible. So are the HMOs, or by means of the HMOs and the hospitals, is responsible, again, for all these things. However, the welfare holds some sort of responsibility because the health system, in its vision, talks about everything that we want. But in reality, things are not exactly on par with that vision. And in the Ministry of Welfare, we are definitely responsible for health services for many people who receive welfare services, especially in, again, day clinics, sometimes inside the community. And in the welfare, we have over 4,000 health professionals or health workers, just for you to understand the proportion. The Ministry of Welfare, in terms of numbers, so look at the slide, look at the groups that we are responsible for in terms of health. 17,500 people with disabilities in, again, out of home frameworks like dormitories, old age homes, post-hospitalization framework, women who suffer domestic violence, and you can see emergency centers that are there, people, juvenile delinquents, people that have a double morbidity. And by the way, somebody came to me before, Nili, she approached me and she wanted to tell me about this NGO she has. Even people with disabilities get dental care, and this is nationally disseminated, but we're still not sure where the health system goes into the picture and where the welfare comes into the picture. But we took the resources also to help the elderly. Of course, inside the community, this is much broader, but let's just say that our approach, what is called, again, welfare health or welfare medicine, our approach is if we give the weaker links in the chain and provide for them, we'll be able to strengthen the entire chain. But here is the elephant in the room. These services are not available, not accessible to people with disabilities. So again, if you did not wear a mask and despite your disability go to get your x-ray, they often won't, they won't perform the x-ray even if they found a lump in your liver. So we haven't really learned from time. We don't have training for how to treat people with disabilities. How many doctors are there that know how to do this? How many psychiatrists took such training of how to deal with people with disabilities? I can't even count them on one hand. Try and create, performing a mammogram to a woman on a wheelchair. Or if she's also cognitively challenged, wow, good luck to you. Do we know how to identify and treat, again, cancer for women that are disabled or have cognitive or are cognitively challenged? Many studies show that we don't know how to do. How about CT? When somebody's lying down, do you know how to do a dental CT? We tried to do so much. There's one place that is located, again, in the welfare services, not in the health services, that will enable dental CT for somebody lying down. Clinics for women with physical access. Is the treatment accessible? Very hard to find. And again, the question that recurs and repeats itself, again, who are we committed to? The guardian, the client himself or herself? Maybe we should be committed to those people who have the disability, right? And after one of those people died during COVID in one of those hospitals, actually, it was a 34-year-old who died despite the fact that somebody called from his institution and told the doctors he only eats, again, purees. They didn't give him the right food and he died as a result. Here is a WhatsApp with one of the seniors in the health services who tried to explain to me that the hospitals, again, are not suitable not a suitable environment for those people. Who are those people? I'm sure you all saw it. I'm not going to read it out. So we have many different types of exclusion, which is sort of factored in because the system is not organized. The system didn't adjust itself to these types of needs. And I keep asking myself the question, will we allow this disability become a limitation, a constraint on treatment? And, even when we publish, a contract and, how accessibility has to be available in different settings, it doesn't include these people with disability. I know, a new circular came out a few weeks ago, I know. And that we have to make all these things accessible in their language, that we know. But what about Braille? What about sign language or lingual abstraction? There's a new circular that came out recently that talks about benchmarks in promoting equality in the health services. Thank you to Sagit Peretz for your courage and for the process. But people with the special needs are not there. They're not there. So again, I applaud everything that is here, but there are things that are missing. Please rectify it. They are not transparent. I want you to include people with disabilities. It goes way beyond what is written here, and so much more has to be done. But this system, again, is not customized in terms of schedules, how appointments are set, and definitely not in terms of physical accessibility. We know this well. And this wonderful booklet that was written when Nir was the head of the strategic planning, Dr. Shlomit Avni, Dr. Emma Averbuch, and when they wrote about inequality in the health system, and policy, health policy, what can we do? We have to remember that when we're talking about these systemic processes that are not divided up as they should be, this leads to inequality, and we have to change the situation. How will it come about? I think through training. We are here in order to carry out these training, to join forces, do them together. We'll have to train the hearts as well. We want to lead change. For people with disabilities as well, I think this would be a very meaningful step forward in diminishing discrepancies, gaps, and inequality. Thank you so much.
טוב. תפתחו מיקרופון.
Please open the mics. And the first question I'd like to address to Idan. The trivial answer to the question how to reduce gaps in health between the center and the periphery is, of course, money. But take all the money you want and send it to the periphery. You talked about capitation, the fact that the HMOs receive more money per head, per person in the periphery. That does not mean necessarily that they earmark these monies for the people from the periphery. Okay, given all the money in the world, how do you solve the problem?
אני רוצה לקחת את ה-case study.
Thank you for the question. I'd like to take the case study of the rehabilitation center that is being set up in the north of the country. It's a wonderful news. People are moving to Ra'anana sometimes to live because a member of the family is hospitalized at the Beit Levenstein Rehabilitation Center, and there was no rehabilitation center in the north, and the government decided to set up such a center in the Poria Hospital in the north. That's very nice. But there was a little asterisk. When they budgeted it, they didn't budget it with a parking lot. Why? Because there's no parking needed in the north. So where are all the workers going to park that are supposed to man this center? They will come with the bus. There is no bus. When you set up a rehabilitation hospital, the evaluation is that you have to mobilize 600 staff, 600 people. So let's say that I tell Mr. Gamzo or the former head of the Ministry of Health or whoever, if he wants to mobilize 600 people for the Sheba Medical Center, he will have as many people as he wants. Clinicians, the physicians, etc. But now we all mobilized, all the heads of local councils, we have the funds, we have the positions. How do we bring 600 professionals to the north? Physicians who will agree to come and live in the north, all the professionals who would agree to live in the north. And why am I telling you that this is not a question of money? Because I have to convince the Israeli Land Authority that perhaps they should give some perk or some benefit to a physician who agrees to come and live in the north.
המשרדים האחרים, ולהגיד להם שאי אפשר להמשיך לדבר על זה.
Perhaps I have to speak to the Ministry of Education to give some assistance. If we do not consider this as a national a horizontal scale mission, if there's no mobilization of the entire government to create this progress that we are so in need of, it will not happen.
מועצה מאוד ירצה ואני אפגש עם כל
Even if the head of the local councils will want it, and I will meet with every potential physician that will agree to come, that will not suffice because I have to find a work for his wife or her husband. And the same problem applies to Jews and Arabs. Because we accept everybody, we can suggest solutions to everyone. Let them only come. So again, it is not an issue of money. It is an issue of a strategy, of a nationwide scale outlook. It's not enough to tell, okay, take a few dozens of millions of shekels and find a solution. That's not enough. Thank you. Sigal, you are a master of the digital and measurement. How do you measure gaps, success, lack of success, failure? How do you measure all that? Please share it with us. Well, by the way, the life expectancy in the north is the higher one. Also in his kibbutz, that also happens. The life expectancy in kibbutzim is the highest. It also stems from better health, from better healthcare systems. Well, that clinic was set up, so, but anyway, he will continue to criticize. It is true that several HMOs in the same place increase competition and bring about an improvement of service levels. Whenever an additional HMO arrives, all the HMOs improve their services. It's true. Certainly another one would improve and provide value, improve the level of service. Now, how do I measure? Well, I spoke about it a little bit. In the beginning, we used the basis of the quality indicators or scores map for children's diseases, cardiological diseases, etc., etc. And so there was a mark or a grade or a score. And in the beginning, we only scored it according to quality indicators. Then we started counting how many specialists and non-specialists we have, and we did a scoring for the inequality, and we could see the inequality, and there was an inequality at the base point, at the 0 point, and even though everyone improves, the gap is still maintained. And we have to look also about the quality and the quantity and quality of the resources allocated, the physical surface, how many small beds, big beds, etc., etc. And the outcomes of quality scores that the people who come to the emergency medicine departments, etc., etc. There are some other indices. Investing in women, we could see that if we invest in the woman or the wife in a family and we start some projects with her, she will pull the whole family behind her, including the husbands. The husbands, in many places, there are neglectful. The woman is usually more attentive, especially because she takes care of the children also. They're more attentive to health, and the men are more easily ill. And so we discovered that more investing in women would promote the issues of distress, nutrition, etc. The wife or the woman will pull the entire family behind her. So it's worthwhile to invest in the women. So we do have some measurements. The problem is not the measurements. The problem is to decide on the right investment and to invest in the community. Thank you. Yael. I know that I can ask you anything. You will respond as you want, but what do you need in order to modify reality? What will help? What would you like? What would I want? Well, in a world of fantasy, I would first and foremost want people to know that there is a connection, there is a link between sexual abuse and morbidity, and it would be of great help to me if I could stop disputing on this issue with the Ministry of Health. It really makes me very tired. So that will help me if they accept what I'm saying in this respect. Well, they also dispute it in the welfare. But that's one thing that would be of great assistance. And then I sat in a meeting with the Minister of Health, and he also asked me that question. And I told him, look, I'm going around the various government offices, and you know what I would really like? I see that you have half a floor in your offices, and I go there and I see cannabis, 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 cannabis everywhere. Half a floor you need for all this thing of the cannabis? Why did you blow this out of every proportion? You created a monstrous system. People have to pay through their noses for something that one could grow in one's own garden. Don't you think that you've gone completely out of proportion? Half a floor, 8 offices for the cannabis people? And he said to me, well, cannabis is a subject that hurts. I don't know. I'm not a user, so I don't know. And I told him, I would like you to just send away all these people of the cannabis. I want half a floor for people who address morbidity of victims of sexual abuse, because we are dying from it. It shortens our lifespan. Israel is by the way no different from the OECD. We have a problem of violence. So what I want is half a floor. He didn't say no. He explained to me that he probably wouldn't be there anymore to see this half a floor. Well, you know, we have elections, etc. So what I would like to see is that people would recognize this. I would like to have people who would address this, who would treat it, people who would measure it, to say we're not being counted. That is not a slogan. Who would count us? Only me in a room with 10 people? You know, some of us already died. They were my friends. We don't know about it. We don't know about you. I'd like to support Yael. We don't know it because we don't ask about it. And I, as a physician, ask anyone who comes into my room, and I know. You can also ask, you know, the family doctors can do that. But if they don't ask, they don't know. You know, you're going forward with gynecology, but this, for instance, has an impact on cardiology. Why don't they ask that, for instance? You know, this is more significant today than overweight, you know? And doctors would speak to me and my friends more about overweight rather than about cardiological impacts. And so if we want to really start researching this and address it, this is really a public health issue, which is of principle. If they don't count you, you don't exist if they don't see you. Thank you. Sarab, I was very curious to know what are the practices that you apply in education and that they could also help the health system. Put yourself in our shoes, and then there will be a question I will ask each and every one of you, and you will have 1 minute to address it, each one of you. How do we cooperate? How do we join hands? Well, the things that I've heard in the report of the decade report and in all the discourses that we heard is there's not enough representation of the periphery population. You talk a lot about the periphery, about especially adapted healthcare systems, but where are the representatives of the periphery? The representatives of the ultra-Orthodox, the Haredim, the representatives of the Arab population. I do not address health issues. I address education issues. So what I can see as significant in education is to show how to work with the population for which we wish to render a service accessible. Where are they? You spoke about the ultra-Orthodox. Where are they? I would like to see in every committee a proper representation, an equal representation of those people that above whose heads we are talking. That's one issue. And the second one is, of course, education. You know, health and indicators and scores are very important. But to increase the consciousness among various walks of the population who do not have access to certain rights, what they can have, what they can't have, and this relates to infrastructure. And the keynote speaker before gave examples of how the environment and the community has an impact on health. And let me tell you a story from last week about especially adapted accessibility. My mother-in-law from an unrecognized village, she has diabetes and she has back pains. And the only way to treat it is medications or injections. I and my husband, we live in Beersheba, and my children, we can walk and we can do sports, we can walk. In that village, unrecognized village, there is no road, there is no sidewalk, there is nothing paved that you could walk on. So this is really the minimum. So infrastructure is really a basic thing. I would like to see more women and men who come from the health field and those in the health field from those sectors that we are talking about. And now, I agree with you wholeheartedly, of course. In the committee, we had all the representation. I would not provide lists right now, but unfortunately, many people, either it was cancelled or they could not come. But it's a question of trust also. In COVID also, we talked about it a lot, and I'd like to say now something on a personal level that we sat together a week ago, 2 weeks ago, and apropos your question, Sagit, we intend to have a course within the Faculty for Health Sciences, which will integrate simulations as regards contending with racism. I'm so glad, Sarab, that you came. It was very important. We are meeting tomorrow, may I remind you? Last question, and start counting the 5 minutes right now. Each one, 1 minute, about cooperation. What type of cooperation from the people who are on the panel, 1 or 2? What type of corporations are you in need of, not necessarily general, in order to allow a considerable progress in reducing gaps? Yael, I suggested to every ministry that works with us to have public hearings, to hear from people who were sexually abused, what are their needs, like in the Katz Ben-Or committee that heard more than 500 victims about their experiences with the authorities. And in spite of our approach, the authority that was much more the most difficult to approach and had the worst scores was the health system. We did a lot of cooperations together with the public hearings with the Ministry of Justice, the internal security. Everything was a big success, but with the Ministry of Health, it was a complete and total failure. So I'm addressing you once again. I'm very interested in having a public opinion cooperations, hearing the public, and to hear from those people what they're suffering from. We're not aware of these people. Let us hear what they have to say and see how we can measure them. I will bring you a little box with cats with personal cards that I will distribute to you and you can approach me later on. I believe that in that sector, you know, when we have people who are completely vulnerable health-wise, we try to map all the connections between the Ministry of Health, the Ministry of Social Welfare, the National Security and everything. When someone is sick and vulnerable and helpless, what you almost, the family almost needs a PhD to do all this, and it has not been resolved yet. We've been talking about it many years. It's not logical. You know, if you have a parent who's ailing in that manner, really you have to go through hell and brimstone if you don't have enough connections in the system. it's very, very difficult. It's one of the most significant hurdles that we have to overcome. And stupid things like if the elderly person is in an old age home, a daily center, they are reducing the hours of the caregivers. Why? So they don't come. Because of those two, there's so many laws that we all know that are completely superfluous and should be abolished. And all this connection it should be a one-stop shop, one point of contact that organizes everything like a case manager. Otherwise, it's horrible, and people really suffer in this period. Idan, you ask about collaborations, and my answer in one word is activism, because my feeling is that the farther you are from the center, when I lived in the center, my feeling of my own agency was great. The more farther away you get and you come to the weaker layers of society, these groups don't even know what to demand and how to demand it. And I think that collaboration, bringing to the consciousness of these sectors of the population that I represent here today, that has to really put their foot down, and we have to assist them to be aware of their rights, of their capacity to change things, their capabilities, not only via the local authority or one crazy person or another who has a bee in his bonnet in this respect, but rather to work together with people who will promote these issues of public health in their communities, and also vis-a-vis the official authorities active in this field, and will demand, and will be with them in daily contact, and will add their voices. I'll give you one anecdote. So you're talking about somebody in charge of health issues in every local authorities, not as a voluntary, but as an appointed person, salaried person. Yes, I have one like that in my council. People in the valley said that they want a gynecologist, a female gynecologist. They don't want to go to a male gynecologist. And the Klalit told me all the time, we don't find a female gynecologist who would agree to come to the Jordan Valley, to live in the Jordan Valley. And then I said, if it was in Bnei Brak, with the Haredim, they would have burnt the clinic already if you didn't bring them a female gynecologist. It's impossible that you will continue to exclude women in the valley just because they don't have any pressure on you, any leverage on you. And then I say, this is an example of joint work, because if all these women would get together, perhaps something would have changed. I definitely agree with Idan. I think that cooperating in the struggle is what is required. The struggle of the periphery against the inequality is not only their struggle, it is the struggle of all of us. So I invite you to come to the periphery, to be there one day and to see what it entails, to have a regular examination, to have to go all the way to Ichilov in Tel Aviv and to make an appointment at midnight to make an examination that is not available to you in the north or the south. So I invite you to join us in the struggle. Thank you. I started with a poem. I shall conclude with a poem, this time of Sigal ben Yair. My mother and I are seeking in the garbage of the various special deals and these buying vouchers. She holds them as a daughter who is hanging on to the dress of her mother. Questions? Thank you so much for a wonderful session. I agree with every word that has been said in this session. I believe the problem stems from something different. I think that the issue of multidisciplinary action, and this is something that you all expressed, and also Sagit's question about cooperating. I believe that the problem does not lie with the people who are here, but in other places. Does the public know how to come and demand from us, as those in charge in various government authorities and civil society bodies, to recognize that there is a link between poverty and periphery and etc. The other thing is the story of the decision makers. we're going to have a new government, a new minister. It's very difficult to come and convince them. So we really need collaboration. You increase the number of physicians from 30 to 100. I don't think they understood the story. The need for a joint narrative in order to convince the decision makers, the Ministry of Finance and the other ministries, that is what is required for us to enable to materialize all these things that we've been speaking about. Thank you very much. No questions? Thank you very much to all.